Okay, so our presentation today is based on a QI project that we did, and that was about improving. It was about improving screening for REM sleep behaviour disorder in patients referred to the Trafford Memory and Assessment Treatment Service, and that was in the GMMH Health Trust. We did this project. It was part of a Neurology Academy bit of a project to try and get people doing QI projects about mild cognitive impairment. So it was kind of off the back of that that we got invited to speak here. So yeah, me and Rachel did the project with our consultants from the team, who is Dr. Amit Sindhi, who is a consultant old age psychiatrist in Trafford, and Dr. Boban as well. Next slide, please. So this is just a bit about why we did the project and why we thought it was quite important. So Lewy body dementia, as I'm sure you're aware, is predicted to be underdiagnosed in the general population. And REM sleep behaviour disorder, that's one of the 4 clinical criteria for diagnosis of Lewy body dementia. And longitudinal studies have shown that there's a really strong association between the two. And it's thought that it could precede the cognitive symptoms of LBD by up to 10 years. So there is a potential there for early identification of Lewy body dementia and then subsequent management of it earlier. So that's why we thought it was an important project. Next slide, please. So what we did was, when we started working as part of the memory team, we noticed that on the screening questionnaires that were coming through prior to our clinic by the memory nurses, we noticed that there was actually no screening question about REM sleep disorder. So we did a retrospective review of initial memory team assessments, and then which were conducted by the nurses. And we got this information from the patient data and visit book, which is part of our service. So we saw that every patient that was screened, we collected baseline data from a sample of patients who had been seen between the 15th of March and the 5th of April 2021. We then extracted data from these initial assessments. And so, like I said, none of these assessments had a screening question. So we looked through the whole assessment, which was, it's very long, it's about 5 or 6 pages long, to see if there was any suggestion of ruling in or ruling out REM sleep disorder. Next slide, please. So then after that, we added in a screening questionnaire to all of the memory assessments that were done. So that question was, have you ever been told that you act out your dreams while sleeping, in brackets, punched or flailed arms in the air, shouted or screamed? So that was added to all the initial assessments. And then we did another round of data extraction from patients with this memory assessment. And that was between the 6th of April 2021 and the 22nd of June 2021. So all patients that had a memory assessment as part of our service were screened at that point. And the outcomes we were looking at, we were seeing if the screening question had been complete. So that was a yes or no answer. And then if it hadn't been completed, why it hadn't been completed. That was part of our work as well. Next slide, please. So this is a driver diagram looking at what we aim to do and the primary, secondary drivers. So our aim was to screen 100% of patients referred to the Trafford Memory Service for RBD over a 3-month period. That was our aim. The primary drivers we looked at, so appropriate identification of symptoms of RBD, increased awareness of RBD a lot around the nursing staff that were doing the assessments and the team that we were with, and a shared responsibility approach. And so how we did this was we did a standardized screening questionnaire. So we added in the validated question, and we highlighted that in red to try and raise awareness of it because it was a new question. Then following this, we did a shared learning teaching to all of the maths team at their MDT meeting, and then we gave that teaching material out to the nurses. And then MDT approaches, we involved admin to disseminate the new pro forma with the nurses. We used the service manager to approve our question and update all the pro formas. The junior doctors, aka me and Rachel, were the ones that provided the education. And then we also used the nurses' feedback about the questionnaire and the teaching to improve our work. Next slide, please. So the stakeholders that were involved in our project were the old age consultant psychiatrists who were mentioned at the beginning, the MATS service managers, the MATS admin team, and the MATS nurses as well. Next slide, please.
I'll step in, thanks Ruth. So for any kind of quality improvement projects that you do, you need to have something that you're going to measure to see if there's been a difference. So we decided that our measure was going to be the completion rate of the screening questionnaire for REM sleep behaviour disorder in all of our Trafford patients who'd had an initial assessment with the memory team. Next slide, please. So here is just a little diagram to just show what actions we carried out through the plan, do, study, act cycles. So in our first cycle, that was the addition of the REM sleep behaviour disorder screening question into our pro forma. So the pro forma itself is quite comprehensive. It is carried out by the community nurses, and it covers a number of different areas. So looking at kind of like memory, how people are functioning, just kind of giving an overview of a comprehensive memory assessment, and it's done before the patient then comes in to see one of the doctors. In our second PDSA cycle, we decided to give a teaching presentation to the memory nurses to really explain why we were doing this project, the importance of the question, and what kind of like value that would add to our patients. And then in our last PDSA cycle, we sent round specific reminders to make sure that all staff were using the correct pro forma. Next slide, please. So here are the results. So sorry, I'm just going to bring this up on my screen. Yeah, so the first PDSA cycle, so this is the initial introduction of the question. So we, at baseline, found that no one was really asking questions around REM sleep behaviour disorder, even though there was like a vague question on sleep. And this initially improved to an 83% rate of screening for REM sleep behaviour disorder. The PDSA2 cycle, so that's when we started to give the educational materials to the nurses on REM sleep behaviour disorder and the association with Lewy bodies and the importance of the projects. So that at that point had increased the compliance with the screening questionnaire to 100%. But as you can see afterwards, the compliance rate kind of tailed off. And what we noticed was that there was still some old forms that somehow slipped their way into the packs that the memory nurses go out to use. So we had a word with the manager and she went through again and made sure that all the new packs didn't contain any of the old assessment performers, and just reminded people to make sure that they were using the most up-to-date performer for that initial assessment. So that was at PDSA 3, and then you can see in the last couple of weeks the compliance again has then increased up to 100% in undertaking that screening assessment question. Next slide, please. So we found that the main reason for non-completion, like we mentioned, was using the old performer. Next slide, please. And then, so at the teaching sessions, it was really good. It was an opportunity to get some qualitative feedback from the nurses as well. So I think the introduction of this question initially into the performer was a bit of a surprise to the nurses. And they didn't really have an understanding of why the question had been included. So they found it really helpful to just give a bit of context as to why we decided to pop this question into the initial memory performer. We had good feedback that the question was really easy to use and administer, and actually about the kind of educational package that we put together for people. They really enjoyed learning about Lewy body dementia and the link with REM sleep behaviour disorder. And I think the consensus was people weren't really aware that there was this link. And I think what I really liked as well is that obviously the nurses have a wealth of experience, and it was nice for them to be able to share stories with us and correlating some of the clinical cases that they'd encountered in the past. Next slide, please. So of the results, so of all the patients' data that we looked at, so 4 out of 152 patients screened positive on this REM sleep behaviour disorder. We actually went on to follow up then the outcomes of the diagnosis. So 1 patient was diagnosed with a delirium. 1 patient was diagnosed with a vascular dementia. Another patient had a late onset Alzheimer's disease, and the last patient had a mixed Alzheimer's disease and vascular dementia. So interestingly, we didn't actually pick up any Lewy body cases from the project, but I think it was quite interesting that having that question in there kind of encourages the clinician to make sure that they're asking about other symptoms. So thinking about visual hallucinations, thinking about any symptoms of Parkinson's, looking for those fluctuations. Next slide, please. Okay, so the conclusions from our project. So we said that introducing this REM sleep behaviour disorder screening questionnaire into the initial assessment has definitely improved screening for a REM sleep behaviour disorder up to 100%. We did feel that further education around REM sleep behaviour disorder is important for all members of our MDT to make sure that we're still asking this question. I think we found that the biggest limitation to our project was that not all patients have a bed partner, so therefore it's kind of difficult sometimes with certainty to screen for that unless it's something that's been historically noted. And yeah, I think that's the next slide, please. That's the end of our presentation, but we're really keen to answer any questions that people might have on the project, or any kind of burning questions that might be present.
Okay, so thank you, and I think it just shows the simplicity of including that question and bringing it to people's attention and raising of awareness of, as you rightly say, one of the core symptoms of Lewy body, and how far in advance that this symptom can actually start to appear. But if people don't get asked that question, because we all know that Lewy body dementia is so, greatly undiagnosed or misdiagnosed. Rachel Thompson, I'd like to invite you as well to come in at this point, whilst people might want to think about putting some questions in the Q&A or the chat box. Rachel, from your experience and your clinical workload, have you seen anything that kind of supports this study about people not being asked this question until kind of quite further down the journey?
Yeah, I mean, I think the whole conversation about sleep and the impact of sleep and picking up changes in sleep is probably fair to say needs lots of improvement, because I think it isn't something that commonly or routinely comes into certainly some of the memory assessment tools that we have. So as you said, Jacqui, because it's such a common feature of people with dementia with Lewy bodies, and is an indicative factor that they may, and as we know, can, I think as you've said, can occur years before a diagnosis. It is really important that we help clinicians recognise the importance of it. So it's really good to hear. What I was really interested in is actually the fact that you, as with any these what you call the PDSA cycles, that you sometimes just introducing something doesn't necessarily change people's behaviour, does it? So you do have to kind of keep reinforcing it. But so that was really interesting. I did have a question, Jacqui. I don't know if we've got.
Yeah, please go ahead.
Yeah, but you said that you didn't in your study so far, that you haven't particularly picked up any cases that hadn't been diagnosed prior. Do you anticipate that might change going forward? What's your thinking about that?
Yeah, I mean, I do. I think the reason that the project kind of came around actually was, well, we'd done this like neurology academy thing, but they gave you lots of like different options of projects you can do. But Dr. Cindy and I had seen a case of Lewy body dementia, which looks like probably had been going on, I think, well, for a long time, and actually retrospectively, maybe the diagnosis could have been made like a couple of years earlier, but one of the core features that the sleep had just been completely missed, and it wasn't until that like 2-year period down the line that these symptoms really started to come out from a more comprehensive history. And then for the 9-month period when I was there, I think we had 2 diagnoses of Lewy body dementia. This is separate to the project. So one of them was that patient, and then another patient was someone who had like a mixed picture. But I think it was just even like in your head, like remembering to really not just asking about, are you sleeping well, is it poor? It's really kind of like exploring that and then going on to exploring some of the other key factors that kind of starts like a trigger for it. So I am confident, like just even like having that awareness that we need to be thinking about it. I think we will start looking for more of the signs. And I think it is hard as well, because I think some of the features do like overlap. So for example, with the hallucinations, for example, we know that hallucinations are not just limited to Lewy body dementia, like we see them in vascular dementia, we see them in Alzheimer's as things kind of progress. So it's really about taking like a really kind of comprehensive history, which is really important. And I think that project's really drummed that in for me.
It's important to note though as well that I mean, it's such an easy thing to do. It hasn't changed the time that the nurses spend doing the assessment. And while our project, it doesn't highlight how important it is in terms of the stats, because we only identified 1.7%, but that was just a snapshot in time. And the nurses were asking every single time, how is your sleep? So we got a lot of sleeps well or doesn't go to sleep on time. So it's not actually changed really the timing of the assessment or how hard the assessment is, but it can actually change somebody's prognosis. So that's why it is so important, and it's so easy to do. So I was quite shocked that it wasn't being done when we kind of started, to be honest.
And I think that's a really important point, that it's not changing the length of time or how hard the assessment is, but it's just such a simple and important question to be asked. We have a question for you in the chat box from Karen Meenam, who's from Lewy Body Island. What are the hallmarks of FTD? Is sleep important for all different types of dementia?
So for frontal temporal dementia, so my understanding is the more kind of like characteristic presentation, it tends to be present in people who are a lot younger. So you're thinking kind of like pre-60s it might present. You tend to see like a lot of the behavioural changes, so that might be more kind of noticeable changes in personality earlier. You might have like disinhibited behaviour, and the memory, although like maybe impaired, is not like at the beginning is not a strong a feature when it's diagnosed in the frontotemporal dementia. So what was the like second part of the question?
Was is sleep important for all the different types of dementia?
Well, I would say my opinion is yes, it is. And even if you kind of think on like any of us who don't have dementia, we know that when someone is sleep deprived, it greatly affects your concentration, it affects your mood. There are so many different aspects of functioning that sleep deprivation does affect. And if you already have that kind of underlying insult to the brain anyway, I think it can almost like sometimes make symptoms worse. And we know that as dementia progresses as well, like we do see a lot of like biological disturbances in sleep, where you might get that, you know, sleep wake reversal. People are like maybe like napping through the day and then they're up a lot during the night is quite a common thing. And I think it links in with like the effect that it might have on people's mood as well. I don't know if Ruth, you have any other thoughts?
Yeah, I definitely agree with everything you said. I think in terms of the REM sleep disorder, that's more linked specifically with Lewy body, and that's why it's kind of like a kind of warning sign of, well, okay, yeah, maybe we think that this is, you know, a standard Alzheimer's or something, but it would make you look more carefully into it if somebody's showing signs of RBD, sleep disorder, because I think that is more characteristic of LBD. But yeah, sleep is hugely important in dementia anyway, and in everyone's life really. But like you say, Rachel, it can change people's sleep patterns hugely and affect a lot of concentration, mood, cognition. So yeah, it's hugely important question to be asking anyway.
Thank you, Ruth. Just a message in the chat box. Message more of a huge thank you to Rachel, which is Rachel Thompson. First time I've seen you, but from my mum and sister, heard so much and wanted to thank you for your kindness. So just a shout out to Rachel there.
Thank you.